Hi, I'm Dr. Kenneth Ellenbogen. I'm a professor of cardiology at the VCU School of Medicine in Richmond, Virginia, and it's my pleasure to be here today with Dr. Hugh Calkins. Dr. Calkins is a professor of medicine at the Johns Hopkins University School of Medicine, and Dr. Calkins was the chair of the AFib ablation consensus document, which was put together via the Heart Rhythm Society, EHRA, or the European Heart Rhythm Association, and ECAS, the European Cardiac Arrhythmia Society. And Hugh, it's great to have you here. I know as chair of this important document, you really had the opportunity to deal with lots of experts all over the world. Can you tell us a little bit about what was involved in putting together this very important consensus document?
Yes, Ken, it was a long process. It took over a year, and it was a big group. It was 45 members of the writing committee, so we identified 45 experts from all over the world, from Asia, from Australia, from Europe, from the US. And again, each of the three societies nominated thought leaders from their region of the world to participate. And then it was a year-long effort where we put the document together, and throughout the process, we would poll the entire writing group anonymously with important questions about indications. So when we say consensus, it's not majority. This was over 80% of the writing group would have to agree to the recommendations that were made. And throughout the document, we include the information we got from these surveys of thought leaders. The document then underwent a very thorough review process by each of the three sponsoring organizations, but it was also endorsed by the ACC, the AHA, and the Society of Thoracic Surgery, as well as APHRS. So each of those organizations had peer reviewers. There were over 400 comments we got back that we had to address each and every one. So we ended up with a document that's quite long. It's 80 pages with over 700 references, but it includes key tables, and we certainly hope it moves this field forward.
Well, I'm sure it will. It's very, very rigorous, very academic. I think for the practicing cardiologist, can you distill the recommendations that came out of this document in terms of what are the type of patients who should be referred for catheter ablation of atrial fibrillation?
Yes, one of the new features of this document is we provide indications for catheter and surgical ablation of atrial fibrillation, and we use a class and level of evidence approach. So, and then we subdivide patients into AFib types. So if you look at a patient who has AFib, who's symptomatic, who's failed a class 1 or 3 antiarrhythmic medication, and they have paroxysmal atrial fibrillation, then catheter ablation is a class 1A indication, meaning it's a very reasonable thing to do at that point, particularly if it's being performed in an experienced center by an experienced electrophysiologist who's skillful at doing the procedure. And then we provide recommendations, again, broken down to whether they've failed drugs or not failed drugs. It's also worth noting that if a patient has not failed antiarrhythmic medication, so first-line therapy, and they have paroxysmal atrial fibrillation, catheter ablation is a 2A indication, meaning it's reasonable. We aren't saying that all the patients should have this done. There needs to be a careful discussion about risk and benefit. And again, we're talking about experienced operators. But again, we provide detailed indications. And then we do the same for concomitant surgical AF ablation. If you're going to the OR to get a new valve and you have AFib, what are the indications? And also for standalone AFib surgery. So again, I think that's one of the most important aspects of this document are the indications.
Well, thank you very much, Hugh. I think that was very useful, a real resource for clinicians to refer to when they have a patient and to better understand what type of patients should have catheter ablation. But you've clearly outlined some patients who are class 1 indications and some of the newer class 2A indications. Thank you very much.
My pleasure.